Next, I'd like to invite Dr. Sapna Patel to present safety and efficacy of first-in-class CXCR12 inhibitor, SXCR12, in combination with pembrolizumab in patients with metastatic melanoma with disease progression on anti-PD-1 therapy.
Thank you. Thank you to ASCO and the scientific committee for selecting our abstract. On behalf of my co-authors, you just heard the title of our presentation. I'll be talking about SX682 in combination in patients with melanoma that's progressed on anti-PD-1 therapy. So chemokine receptors 1 and 2, CXCR1 and 2, are 7 transmembrane domain G protein coupled receptors. They're activated by a number of redundant chemokines that are often overexpressed in cancers. And specific to melanoma, they're known to drive growth by autocrine signaling, by inhibiting the immune microenvironment through the recruitment of MDSCs, and through promoting angiogenesis. SX682 is a small molecule, oral, allosteric dual inhibitor of CXCR1 and CXCR2. It has an IC50 between 20 to 40 nanomolars and a human half-life of approximately 19 hours. Sensitive. Specific to melanoma, CXCR2 expression inversely correlates with survival in melanoma patients who've been treated with anti-PD-1 therapy. Similarly, interleukin-8, CXCL8, the ligand for CXCR1 and 2, also inversely correlates with survival in the same population of patients who've seen anti-PD-1 therapy. In melanoma mouse models, SX682 alone reduces melanoma tumor growth and increases CD8 infiltration into the tumor microenvironment. And this result is enhanced with the addition of anti-PD-1 therapy. So the study design was a phase 1, first-in-human, dose escalation and dose expansion of SX682 given in combination with pembrolizumab in melanoma patients who had progressed on prior anti-PD-1 therapy. The study has a monotherapy run-in where SX682 is given alone and then combined with pembrolizumab. And it had another cohort where the combination was directly started. So no run-in, SX682 direct to combination with pembrolizumab. The primary endpoint of this phase 1 study is safety and tolerability of both the monotherapy run-in portion as well as the combination portion. Secondary endpoints include clinical efficacy and tumor-based pharmacokinetic, pharmacodynamic, and correlative studies. All subtypes of melanoma were eligible for this study with the exclusion of ocular melanoma, and treated asymptomatic stable brain metastases were allowed. There were tumor biopsies collected at cycle 1, day 15, and longitudinal serum collected throughout study. This is the baseline demographics. You can see it. In total, 51 patients were enrolled across various dose levels. The median age was 65. Median target tumor burden, 75 millimeters. 63% had an elevated LDH, and 73% of this patient population had seen prior nivolumab plus ipilimumab. So for DLTs, in just the monotherapy run-in, there were no DLTs at any of the dose levels of SX682. 200 milligrams twice a day of SX682 as a run-in had no DLTs, but once combined with pembrolizumab, DLTs occurred. When SX682 at the same dose of 200 milligrams twice a day was given direct to combination with pembrolizumab, there were no DLTs. So on the basis of that safety data, as well as some pharmacokinetic and pharmacodynamic data, the 200 milligrams twice a day of SX682 direct to combination with pembrolizumab was selected for dose expansion. So treatment-related adverse events occurred in 75% of patients on study, in whom drug discontinuation occurred in 43%. When we excluded uncomplicated neutropenia, so bone marrow trafficking happens of your neutrophils when you block CXCR2. So uncomplicated neutropenia is considered a permissible side effect. And when we excluded that, the grade 3 adverse event rate was 25%, as opposed to 43%, was 25%, and the drug discontinuation rate went down to 12% from 20%. Sorry, I got those numbers a little confused. And those drug discontinuations were due to rash and transaminitis. Importantly, despite the signal of neutropenia, this was uncomplicated neutropenia, and there were no instances of febrile neutropenia, and there were no infections reported. At SX682 doses of less than or equal to 100 milligrams twice a day, there was no demonstration of clinical benefit. All 9 patients experienced progression of disease, but at 200 milligrams twice a day, the objective response rate was 21%, with 63% achieving disease control. Importantly, all patients with disease control had progressed on prior IPI and Nivo. 3 of these patients achieved a partial response with SX682 plus pembrolizumab. Here's the duration of response as a swimmer's plot. And you can see the 4 partial responders are noted with a plus sign. The time on treatment is shown here in blue, with the time in follow-up or survival shown in red. At the time of this data cutoff, the majority of these patients are alive, and 3 patients remain on treatment. This spider plot shows the kinetics of the change in tumor burden, and it's shown in color by dose level of SX682. And so what you can see is at doses of less than or equal to 100 milligrams twice a day, there was a majority increase in tumor burden, whereas at doses of 200 milligrams twice a day, there was a trend towards more of a decrease in tumor burden. At doses exceeding 100 milligrams twice a day of SX682, the blood levels exceeded the therapeutic target predicted by animal models. And so this was supported by the clinical dose responsiveness that we saw. In this representative patient who was treated at SX682, 200 milligrams twice a day, at cycle 1, day 15, you can see at both low and high power an increase in the infiltrating CD8 positive T cells into the tumor microenvironment. This was during the SX682 monotherapy period prior to the initiation of pembrolizumab, and the best objective clinical response in this patient was ultimately a partial response. And in an exploratory analysis of PFS, progression-free survival, and overall survival segregated by dose, you see that doses of SX682 at 200 milligrams twice a day led to a numerically higher PFS of 4.1 months versus 2.1 months at doses of 100 milligrams twice a day. And an overall survival of 15.9 months compared to 6.2 months at doses of 100 milligrams twice a day. So the 200 milligrams twice a day exploratory has a better PFS and OS, at least numerically. So in conclusion, there were no dose-limiting toxicities at the maximum tolerated dose of 200 milligrams twice a day of SX2 given direct to combination with pembrolizumab. And excluding the uncomplicated neutropenia, which is a permissible pharmacodynamic effect, bone marrow trafficking on the neutrophils, there was a 25% grade 3/4 treatment-related adverse event rate and drug discontinuation in 12% due to rash and transaminitis. In patients with prior progression on anti-PD-1, the 200 milligram twice a day combination with pembrolizumab produced an objective response rate of 21%, disease control in 63%, a median PFS of 4.1 months, and a median OS of 15.9 months. And the pharmacokinetic and tumor microenvironment studies support that it's SX682 helping to mediate these effects at a dose of 200 milligrams twice a day. I'd like to thank the U.S. North American study sites, the PIs, as well as the team members at Centrix Pharmaceuticals, the patients who enrolled in this study, as well as the families, caregivers, and the National Institutes of Health for the Small Business Administration grant that helped to support this trial. Thank you very much.
And I'd like to invite Dr. Meredith McKean to discuss these three.